Good morning, everyone. You're welcome to today's fortnight academic session. Dr. Abdulkarim Abubakar of National High Center Kaduna will be presenting sudden loss of vision in a 60-year-old hypertensive. Dr. Abdulkarim, you have the floor.
Good morning, my senior colleagues and respected brethren in ophthalmology. This morning, we'll be discussing a case of sudden loss of vision in a 60-year-old hypertensive. We follow this outline in our discussion. Sudden loss of vision simply means with usually unexpected loss of the ability to see, blurring of vision, or even loss of the ability to see at all. It's a medical emergency, and sudden loss of vision can happen in a couple of seconds, minutes, or even over 2 days. Hypertension is a non-risk factor for most systemic conditions that can lead to end organ damage, including the eye, the heart, the brain, and the kidney. So hypertension is defined as high blood pressure. The commonly known classification of high blood pressure we know is that of the reports of the Joint National Committee for the Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, commonly known as the JNC7, which classifies high blood pressure as any blood pressure that has a systemic of less than 120, the systolic of less than 80, so it's classified as normal blood pressure, and a systolic blood pressure of 120 to 139, and the diastolic of 80 to 89 as a pre-hypertension or grade 1 hypertension. A pre-hypertension. So while systolic blood pressure of 140 to 159 or diastolic of 90 to 99 as mild hypertension or grade 1 hypertension. And a systolic blood pressure of 160 to 179 or diastolic of 100 to 109 as moderate hypertension. Any systolic blood pressure of 180 or above, or any diastolic of 110 as above is an accelerated hypertension or hypertensive crisis. So when it's 180 systolic and diastolic of 120 or greater than 110 with no end organ damage, hypertensive urgency, while with end organ damage, it's hypertensive emergency. This is an old classification of high blood pressure. A recent review of classification of heart pressure of high BP is that of the American College of Cardiology and the American Heart Association, which was revised in 2017. So has a lower value of high blood pressure, in which 120 to 129 as systolic, or any diastolic that is 80 or beyond is high blood pressure. So don't forget our patient is a non-hypertensive that present with sudden loss of vision. What are the likely causes of sudden loss of vision in this patient? A hypertensive and elderly. So hypertension can have profound direct and indirect effects on the eye. So the sudden loss of vision in this patient can be as a result of the direct effects of the elevated blood pressure on the ocular tissue, which could be either hypertensive retinopathy, hypertensive choroidopathy, or hypertensive optic neuropathy. Again, systemic hypertension is also associated with worsening of certain systemic conditions like the diabetic retinopathy. So if this patient is also diabetic, the hypertension can worsen a presentation of diabetic retinopathy. Also, there is increased risk of secondary ocular diseases including branch retinal vein occlusion, central retinal vein occlusion, blunt retinal artery occlusion, and central retinal artery occlusion. Ischemic optic neuropathy, especially in this patient, could be non-athertic, or the patient can have macroaneurysm that is close or at the macula, close or at the macula. It's been found that about 30% of adults, 30% of adults are approximately hypertensive. The crude prevalence in Nigeria that was conducted in 2023, the crude prevalence of pre-hypertension is about 30.9%, while that of hypertension, that is systolic blood pressure of 140 and above, or the systolic of 80 and above, they are about 30.6. The incidence of hypertensive retinopathy changes, or hypertensive retinal changes, actually are variable and can often be masked by the presence of other vascular diseases, such as the diabetic retinopathy. So the incidence is actually variable. Hypertensive retinopathy can occur from 2 to 17% in non-diabetic. So there was a study that was conducted to study solely the diabetic retinopathy. That means to study patients that are only hypertensive, they don't have other vascular diseases. That's the Viva DAM-I study. It studied just hypertensive patients. And the prevalence of hypertensive retinopathy in those patients was found to be about 15%. To be precise, 8% retinopathy, and other percentage showed atrial narrowing, and like 2% showed arteriovenous leaking. So hypertensive retinopathy is more common in African Americans. So it's common in Black. And it's found that men are more affected, especially in young age, 40 years and below. And in the elderly, which our patient falls into, women are more affected. Hypertension, systemic hypertension can either be essential, like primary hypertension, or secondary to other background diseases. So the risk factors for systemic hypertension include intake of high salt diet, a patient that is obese, use of tobacco or alcohol consumption, family history, and ethnic background. As I mentioned, it's commoner in Black. There are some certain genetic predisposition also identified to predispose to hypertensive retinopathy, like the D deletion in the angiotensin converting enzyme has been found to be implicated in the development of hypertensive retinopathy. So if a patient is hypertensive, the hypertensive retinal changes occur usually as a result of the duration of elevated blood pressure. So atherosclerotic hypertensive retinopathy is due to duration. How long has the patient been diabetic? So has the patient been hypertensive? This is very important and should be asked in our history checking. So, and also the major risk factor for the development of malignant hypertension is the amount of blood pressure elevation over normal. We all know the normal, less than 120 systolic, diastolic of less than 80. So the amount, the higher the value of systolic elevation or diastolic elevation has been found to be the major risk factor for the development of malignant hypertension. So this sudden loss of vision and other retinal changes that occur in a hypertensive patient actually follow 3 phases. And these phases include the vasoconstrictive phase, the exudative phase, and sclerotic phase, and also its associated complications. So in the vasoconstrictive phases, usually due to the high systolic blood pressure or high BP, in order for the body to respond, there is a reversible stimulation of the vascular tone of the muscular retinal artery as an autoregulatory mechanism. because the body has been used to normal blood pressure. Now the blood pressure has been elevated. So for the body to compensate, there is an autoregulatory mechanism, which is enhanced by reversible stimulation of the vascular tone. So when there is prolonged blood pressure elevation, this will lead to arteriolar narrowing, especially at the precapillary level. This arteriolar narrowing, in association with the vasospasm, will lead to the reduced blood flow distal to the point of this narrowing. This reduced blood flow could further lead to ischemia and hypoxia. And this ischemic changes, especially in the retinal nerve fiber layer of the retina, could be seen clinically as the cotton wool spot. Again, we all know the ganglion cell layer converge to exit the ocular surface through the lamina fibrosa. So we know this is a tiny exit. So any interruption as a result of the elevated blood pressure could hinder the axonal autograde or retrograde transport of these ganglion cell axons, which is usually energy dependent. So this could subsequently lead to swelling of the optic disc. All these are part of the constrictive phase. So in the exudative phase, because of the persistent elevation or high elevation of blood pressure, there will be disruption of smooth muscles of these arterioles or retinal arteries with associated necrosis. We know the barrier, the main barrier that prevents communication with these blood vessels and the retinal tissues is the inner blood retinal barrier. So if there is disruption of this smooth muscle, invariably there will be disruption of this inner blood retinal barrier. This could lead to leakage of plasma proteins and also plasma into the vessel wall around the peripheral and arteriolar muscle cells. If there is bleeding from this vessel, that bleeding could also leak and could present as retinal hemorrhages of various sizes and locations. It could be deeper or around the retinal nerve fiber layer. Again, the transudation of these plasma proteins and also plasma could also lead to an accumulation of fluid around the macula. In hypertensive patients, this fluid accumulation around the macula has a peculiar pattern of macular sac. So if there is this proteins and lipid exudation, transudation also would eventually lead to hard exudate. So the next phase is sclerotic phase. The layer of the endothelial wall of these retinal vessels undergo certain changes. You know, because of the hyperstimulation of these retinal vessels to compensate as a result of the autoregulatory mechanism, there will be thickening of these blood vessels, especially the intimal layer of the blood vessels. And also there is vascular tunica media hyperplasia and some hyaline degradation has been noted in the arteriole. So worsening arteriolar narrowing because of atherosclerosis could cause certain changes in the retinal vessels, especially arteriovenous crossing, which would subsequently, this atherosclerosis could subsequently be seen as copper wearing and silver wearing, as the case may be. So to summarize, if there is systemic chronic hypertension, compensatory mechanisms from the body, especially end organs, in the end organs like retinal arterioles or retinal vessels, there could be atherosclerosis is dominant. So this could lead to narrowing of retinal arterioles. Eventually, because it is narrowed, there will reduce flow. Distal to the point of narrowing could lead to ischemia. So if there is reduced blood supply to that area, oxygen supply could also be reduced. There will be hypoxia. With subsequent damage, there could be increased capillary permeability. Then finally, focal retinal edema, retinal hemorrhages, cotton wool spot, and heart exudate could be noted. In this patient, clinically with the ophthalmologist, this patient needs to be thoroughly examined after taking a detailed history. As we all know, systemic hypertension is asymptomatic. So if it is chronic and severe with end organ damage, some patient will present with certain symptoms. Blurring of vision is of paramount importance to the ophthalmologist. And the ophthalmologist should be very attentive in examining this patient. A dilated fundoscopy is the answer. And certain changes could be looked for, which can differentiate the disease from other likely causes of sudden loss of vision. So we'll be looking for generalized arteriolar narrowing, changes of the arteriovenous crossings. We'll be looking for plane-shaped hemorrhages, which are usually hemorrhages that occur in the nerve fiber layer, microaneurysm, or macroaneurysm, as the case may be, exudate, cotton wool spot, optic disc swelling, especially in malignant hypertension. So this is a normal disc or a normal fundal photo. So we can see the retina appears pink. We can see the retinal veins. So if we look very carefully, the arteries and veins has its independent course. They hardly cross each other in normal patients. And a patient that is hypertensive, especially chronic hypertension, if you look very carefully, there could be, because of the atherosclerotic changes of the retinal vessels, there could be generalized narrowing of the retinal arteries or arterioles. And if we note very carefully here, this is a tributary to the inferior temporal arcade, or from the inferior temporal arcade. And this is also one of the tributaries. So we can see there is a crossing of this tributary by this arteriole. So this is one of the hallmarks of hypertensive retinopathy. It's called the arteriovenous nicking. And if we see here, though not very clear, there is focal arteriolar narrowing. Again, if we look very carefully, this is also another one. We can see this is the point of crossing. This is the arteriole. We can see it's losing its normal texture or reflex as you examine on fundoscopy. Is becoming a bit harder because of the atherosclerotic changes. So it's crossing over this tributary, and there's another crossing here. So there are certain important signs that you need to look for that could also give a guide to establish your diagnosis. So as I mentioned, these are arteriovenous crossing. So if we look very carefully, this tributary or this vein, retinal vein, you can see here is straight, and also here is straight, here is also straight. But at the point of this crossing, if we look very carefully, there is an angulation here. There is also an angulation here. That is a deflection sign. We call it the stalus sign. So deflection of the veins at the point of crossing. And also, if we look very well, the edges of this vein close to the artery that cross over the vein is a bit tapered, a bit narrow. So this tapering of the cross over retinal vein is known as the Gon sign. We can see it here very clearly. There is tapering at either end. This is the Gon sign. And if there is branching of the vein distal to the point of obstruction, the vein could be very narrow compared to the proximal end. That's the bonnet sign. So on fundoscopy, normal retinal vessels, especially the arteries, they have a bright, thin linear reflex. However, if atherosclerotic changes begin to take effect, the thin linear reflex could become broad and it becomes less bright. So the reflex is a bit diffuse and also will be less in brightness. This is especially seen in grade 1 and 2 hypertensive eye disease. So as the disease progresses, copper wearing or silver wearing could ensure. So this is a schematic diagram to show some of the changes that I mentioned earlier. So we can see the hemorrhages here, they are a bit tapered. These are the flame-shaped hemorrhages. They are usually found at the retinal fiber layer. Sometimes dots and blood hemorrhages could be seen in hypertensive retinopathy. And this occurs when the bleeding occurs in the deeper layers of the retina. So as I mentioned earlier, these are hard exudates around the macula. So when the blood pressure is markedly elevated, a patient may tend to be tilted towards malignant hypertension. So rapid progression of hypertensive state in a patient, especially younger patients. So malignant hypertension may not be likely in our patients. So in malignant hypertension as well, the patient could have retinopathy, choroidopathy, and optic neuropathy, as earlier highlighted. So this is a fundal photo also depicting the pattern of exudate seen in hypertensive retinopathy. You can see the exudate around the macula like a star. It's called macular star. So this is the pattern of exudate in hypertensive retinopathy. So another likely cause of sudden loss of vision in our patients could be hypertensive choroidopathy. So in hypertensive choroidopathy, These are some of the features we look into or we look for. And as I mentioned earlier, hypertensive choroidopathy is commonly seen in malignant hypertension, especially when the blood pressure is about 200 or above and diastolic of 140 and beyond. So this patient could be properly evaluated and referred accordingly, because any patient that has malignant hypertension and has some choroidopathy has an associated risk of cardiac, renal, and cerebral involvement. So, as I mentioned, the pathogenesis of hypertensive retinopathy is similar to hypertensive choroidopathy, mainly due to the auto-regulatory mechanism. So some of the features we look for on fundoscopy are the ethnic spot, degree streak, and some patients may present with exudative retinal detachment. So you can see here as a yellow halo with a black support in the center. So this finding, eclipse spot, is actually as a result of the choroidal arterioles undergoing aggregate necrosis, especially due to the vessel wall damage from severe spastic narrowing. So this could result in patchy, non-perfused areas of the choriocapillary, and the overlying retinal pigment epithelium appears yellow. This is because of focal ischemia and ischemic impact. Again, the Sigrid streak also, we can see the streak here is just a line that is also one of the pathognomonic of hypertensive choroidopathy. It's also as a result of fibrillary necrosis that occur in hypertensive retinopathy. By way of classification, there are various classifications in hypertensive retinopathy. The Kaduna-Barker classification, the commonly used, which graded hypertensive retinopathy from grade 1 to 4. So in grade 1, if there is slight narrowing, sclerosis, and tortuosity of the retinal arterioles. Grade 2, if there is definite narrowing, focal constriction of the arterioles, and arteriovenous crossing. Grade 3 is grade 2 with associated cottonwool spots, hemorrhages, and exudates. And grade 3, if there is neuroretinal edema. So this is grade 1. If there is mild generalized arteriolar attenuation. As I mentioned earlier, because of the atherosclerotic changes in the arterioles, on fundoscopy, the thin light reflex is becoming broader. So there is broadening of the arteriolar light reflex. So if there is increase in this narrowing, or if there is focal attenuation of this arteriole, we think of grade 2 according to the Kettwagner. So in grade 2, the stylus sign is apparent. We can see the angulation here, the deflection. You can see the retinal, you can see the deflection, So in grade 3, there is increased thickening of the atrium because of increase in the atherosclerotic nature of that blood vessel. So the blood vessel will appear like a copper wire. And this is the gun sign, the silent arteriovenous crossing, and also the deflection. So in grade 4, with the severe form of hypertensive retinopathy, all the changes seen in grade 3 with silver wearing of blood vessels do not apparent here, and papilloedema. This another classification for hypertensive retinopathy. The G classification grades hypertensive retinopathy from 0 to 4 as against the Wegener 1 to 4. So grade 0, if the patient is hypertensive, but normal fundal findings. Grade stage 1, there is diffuse arteriolar narrowing, no focal constriction. More pronounced arteriolar narrowing with focal constriction in stage 2, and the focal narrowing and diffuse narrowing associated with retinal hemorrhages grade 3. So when there is retinal edema, heart exudate, optic disc edema, that's stage 4. The C classification has two components. One related to the retinal findings, and the other one to the stages, the atherosclerosis. So stage 1, the patient is hypertensive and no feature of atherosclerosis seen. So grade 1, broadening of the large reflex with minimal arteriovenous compression. Grade 2, large reflex changes over the crossing blood vessels. Grade 3, copper wearing, and grade 4, silver wearing. So we can see here, you barely differentiate the artery and the vein. So if you look here very carefully, there is some changes. You can be able to see this one is becoming more brighter. If you see here, you can see the vein. See at the point of crossing here, each of the blood vessels is straight. But after the crossing here, you can see the bonnet sign. Sorry, the Gallus sign. You can see the angulation. As well, the bonnet sign, you can see the tapering. So also here, the blood vessel is becoming more prominent. And here it's more obvious. This is the silver wearing, this stage, or grade 4 of the atherosclerosis. So there is modified classification. Grade 0, no changes at all. Barely detectable arteriolar narrowing. Obvious atrial narrowing, focal irregularities. Grade 2, if there is narrowing in association of which there is a retinal hemorrhage or retinal exudate or combination of both. And grade 4, if there is disc edema. So the diagnosis of this patient is usually clinical. So a detailed history and examination findings using dilated endoscopy with use of direct indirect ophthalmoscopy could guide in establishing or could help to establish the disease in this patient. So the patient could give a history of loss of vision with associated headache, and the patient could give history of having hypertension. So on examination, all the changes that we've seen in the course of the presentation could be seen. Some of the differential diagnosis in this patient, a CCA hypertensive with sudden loss of vision. The differential diagnosis could be as a result of the indirect effect of or diseases in association other vascular diseases that could cause sudden loss of vision, like diabetic retinopathy or central retinal vein occlusion. Even in branch retinal vein occlusion or hemiretinal vein occlusion, especially if there is associated macular edema, the patient could present with sudden loss of vision. And if the patient also has or presents with macroaneurysm on or around the macula, especially if there is retrohyarid hemorrhage, so the patient could present with sudden loss of vision. This is slide just to show some differences between hypertensive retinopathy and diabetic retinopathy in terms of their exudate. Commonly or typically, in hypertensive retinopathy, the exudate appears as a macular star, while in diabetic retinopathy, we commonly see cisnet exudate, sometimes incomplete, just some exudate, depending on the severity of diabetic retinopathy. And flame-shaped hemorrhages are commoner in hypertensive retinopathy. Again, continuous spots are commonly seen in hypertensive retinopathy. You may or may not see microaneurysms, but are more pronounced in diabetic retinopathy. And dot and blot hemorrhages are more prominent in diabetic retinopathy. In severe hypertensive retinopathy, especially in malignant hypertension, it may have a similar presentation with retinal vein occlusion, especially central retinal vein occlusion. It may present with marked disc edema. However, the typical pattern of the macular exudate are not usually seen in retinal vein disease. So the management of this patient is actually a multidisciplinary. So the ability to identify the disease area and refer to appropriate physicians could help in saving the life of this patient. As we highlighted earlier, hypertension is a systemic disease that predisposes to end organ damage. So management of this patient could include an ophthalmologist, cardiologist, nephrologist, and a neurologist, as the case may be. And the mainstay in treatment of this patient, especially the retinal changes, and other end organ affectation, is lowering the patient's high blood pressure. So good blood pressure control is the mainstay in management of this patient. So the patient could be advised or should be advised for lifestyle changes to avoid sedentary lifestyle, and also to promote healthy lifestyle in terms of exercise and healthy feeding. And the patient could be referred to appropriate team for proper management. So in hypertensive retinopathy, in mild hypertensive retinopathy, good blood pressure control could be sufficient in managing this patient. So in moderate to high hypertension, the BP control alone could not be sufficient because the patient could have an advanced atherosclerotic changes. So it's good to evaluate this patient lipid profile and other risks that could predispose to worsening symptoms and treat accordingly. So if lipid abnormality is found, so use of cholesterol lowering agent could come into play in addition to the BP control. And in accelerated hypertensive retinopathy, there could be room for urgent antihypertensive. In management of this patient also, investigations that could be of help, as I mentioned, at the baseline investigation, you need to evaluate this patient, request for fasting blood sugar, lipid profile, low density lipid profile, and total cholesterol, which could predispose to the worsening of symptoms in this patient. Fluorescein angiography, not usually necessary. However, if there is an indirect effect of this hypertensive retinopathy in the eye, maybe one has some features suggestive of central artery occlusion or central retinal vein occlusion, he may wish to request fluorescein angiography. In central artery occlusion, as we know, because of the atherosclerotic, there will be delayed filling of the arteriole. And in central retinal vein occlusion, there could be leakages, among other changes that could be seen. So the prognosis in the management of this patient actually depends on the severity of the disease and the level of the presenting blood pressure. Studies have shown that a patient with exaggerated high blood pressure, especially malignant hypertension, so the mortality rate, if these patients are left untreated, is about 50% in 2 months and about 90% in 1 year. And also, their prognosis depends on other associations. Since the atherosclerotic changes in these retinal vessels are irreversible, all these atherosclerotic changes we mentioned above cannot be reversed. So this patient is at increased risk of developing central retinal artery occlusion, central retinal vein occlusion, and also macroaneurysm. So this patient should also be counseled appropriately. And the follow-up depends upon the degree of hypertensive retinopathy and other associations. Likewise, the treatment. If there is no other risk predisposed, like central retinal vein occlusion, macroaneurysm, this patient can do with the above treatment we mentioned. However, in association with other diseases, other vascular diseases, the central retinal vein occlusion with macular edema, the patient should be treated accordingly. I'm sorry to mention, fundal photo is very important, which could be used in educating this patient. Likewise, OCT can be of help, especially if we're thinking of macular edema. It can also be used to educate the patient and also monitor our management. Because if this patient has macular edema, so the macular edema could be treated accordingly, whether with the use of laser, focal or grid, or use of intravitreal anti-VEGF. Again, if the patient has predisposed to macroaneurysm, especially if there is retrohyaloid hemorrhage, there is room for laser hyoidotomy to puncture the collection so that the blood drains into the vitreous chamber. If it's cleared subsequently, fine. If it continues and leads to vitreous hemorrhage, then the patient would also be treated accordingly. And the follow-up of patients with hypertensive retinopathy is actually individualized. However, as I mentioned, there should be a synergistic if there should be a close contact between an ophthalmologist and other managing physicians to save the life of this patient. In conclusion, early identification of high blood pressure, which we know is usually asymptomatic, so it's very vital. This is based on the fact that elevated blood pressure increases the risk of stroke, coronary artery disease, retinal disease, and also could lead to death. So retinal examination can aid in the diagnosis of systemic hypertension. In some of these patients, it's the ophthalmologist that will first diagnose and refer to the appropriate physicians. So retinal examination should be diligent, which could aid in the diagnosis of this patient, and also risk stratification for secondary scoring, as I mentioned earlier. Also, pharmacologic treatment is recommended for mild diseases, or rather for stage 1 and 2 diseases. While for mild diseases, especially pre-hypertensive, lifestyle modification are suggested. These are some of my references. Thank you for listening.
Thank you very much, Dr. Abdulkarim, for the detailed presentation. We now welcome questions and comments from the audience. Okay. I have no question in the, okay, there's a question there is a comment in the chat box. Okay, so somebody says, common things occur commonly. I had this patient yesterday, 50, female, 45-year-old, sudden loss of vision of 3 weeks duration, no headaches or trauma, non-hypertensive but not regular on medication, blood pressure 180, 140 millimeters of mercury, ocular examination, perception of light, sluggishly reactive pupil, dilated fundoscopy, battlefield appearance, widespread hemorrhage, and disc edema, and dilated tortuous vessels. Okay, thank you for that. Thank you for sharing your experience, Dr. Oyediji. Okay, the next is, thank you for the presentation. Why is central retinal artery occlusion not one of the differential diagnoses of hypertensive retinopathy? That's a question, Dr. Abdulkarim. Then the second is, can type 3 papilloedema be one of the differential diagnoses? And then the third is, how would you differentiate hard exudates from cotton wool spots? So I hope, okay, then another person is asking, what's the difference between copper wiring and silver wiring? Dr. Abdulkarim, would you like to respond to these questions?
Okay. Thank you, Mom. Okay. As I mentioned earlier, some of the indirect effects of hypertensive retinopathy could be central or retinal vein occlusions or retinal vessels occlusion, being it central retinal vein, central retinal artery, among others. I just mentioned few. Central retinal artery could be. However, there are certain features you see in central retinal artery that you could not see in isolated hypertensive retinopathy, like the cherry red spot, and also the hemorrhages are not very common or are not very prominent in central retinal artery. And also the macular star we mentioned, the exudate accumulation around the macula are also not very common. And again, in central retinal artery occlusion, the retina, the fundus appears a bit pale because in central retinal artery occlusion, the retinal changes are as a result of an ischemia, generalized ischemia. So it could actually be a differential diagnosis. I just mentioned few and listed some differences. Yes, papillary edema can be a differential. And however, we know papillary edema has typical presentation of disc edema, retinal hemorrhages, obscured disc margin. However, the age of presentation, hypertensive retinopathy, our patient is an elderly patient. So papillary edema can be a differential, but it's commonly seen in younger patients, especially females. Yes. Heart exudates
Yeah, the question is, how would you differentiate hard exudates from cotton wool spots?
Yes, so look very well here. You see, these are hard exudates, though a confluent, and these are cotton wool spots. So if you look from the size, cotton wool spots appears larger than hard exudates. You see, this is an exudate. This is a cotton wool spot. So the cotton wool spot appear larger, and hard exudates are usually small. They are white to yellowish in appearance, while cotton wool spot may also appear like yellowish or white. However, hard exudates are smaller. And again, in hard exudates, their margins are their edges are very clear and sharp. So this is a confluence to be difficult to appreciate. But if it is an isolated exudate, the edges could be well identified, very clear and sharp. While in cotton wool spot, they may have an irregular edges. Their margins could not be very sharp and could not be very clear. These are some of the features to differentiate between the hard exudates and cotton wool spot. And by way of pathophysiology, the cotton wool spots are commonly because of the ischemia of the retinal nerve fiber layer. And we know the orientation of the RNF layer. So sometimes the cotton wool spot may tend to obey the orientation of the layer of the RNF. While hard exudates could be anywhere, however, they appear to occur deeper in the retina. These are some of the features I can remember.
Okay, thank you very much. The next.
Pardon? I can hear you, please.
Sorry, did you get that?
Hello, Chief, I can hear you. You are breaking.
Yes, okay. So what's the difference between silver and copper wiring?
Okay. As I mentioned earlier, as a result of atherosclerosis and atherosclerotic changes that occur in the retinal blood vessel. So the blood vessel was supposedly normal initially,
But because of increasing atherosclerosis of the intima and the media of these blood vessels, the blood vessels become thicker. So this increase in thickness, is graded, as I mentioned in the C classification of atherosclerosis. So the lustre appearance of the thin, you know, you are doing fundoscopy. So in normal blood vessel, you expect to see a very thin and bright reflex. So if there is this vascular wall changes as a result of atherosclerosis, the first stage it would reach is the copper wearing. So in the copper wearing, there will be broadening of this thin reflex. And in silver wearing, the retinal arteries look white. This as a result of it being occluded. So it will just appear very white. Sorry, yes. So you can see from this picture, you can see this vessel, this artery it appears very white as compared to this. So this is the copper and this is the silver. And this as a result of occlusion and hardening of this blood vessel because of the atherosclerosis. I'm sorry, I don't know whether I have made some sense.
Yes, yes. Thank you very much. I don't think we'll be able to take all the questions. We have a lot of questions and comments in the chat box, but I'll just take the last one. One last one. So somebody says, thank you for the presentation. Can you share your slide on differential diagnosis again? I think that will be the last for today. Can you share your slide on the differential diagnosis?
Sorry, I'm moving. It's not moving.
Maybe it's the network.
It's not moving.
But please, I think the recording will be shared. Sorry. Somebody asked a very important question that for the sake of part 1 exams, if they would just give differentials of sudden loss of vision, if maybe people can just quickly type it in just to help us remember all these things, because the essence of this presentation is like, since we're not able to come together or to have group discussion, this is like a group discussion. So I think it'd be nice to answer that question too.
Okay, is it a question? Hello?
Yeah.
Yes.
Yeah,
so the person asked that, please, can you emphasize concept of sudden reduction of
Okay. Sorry, my network is bad. Okay. I can't hear you.
Sorry, Dr. Abdulkarim, Dr. Umulakhair. Let me quickly come in. Dr. Abdulkarim, what? Hello, can you hear me?
Hello?
Hello, Dr. Abdulkarim, can you hear me?
Yes, I can hear you.
Okay, thank you. Dr. Fumi, I think it's okay. We can't hear you. Your network is bad.
Benefits of those writing part 1.
Yes, we got that, Dr. Fumi. Please, let him just quickly answer the questions. He can't hear you clearly. So, Dr. Abdulkarim, what they are all trying to say is that quickly give a summary, like differential diagnosis, that people writing part 1 will be expected to list and probably talk about in their differentials when they're, when you talk about history examination. So they should be seen to be asking relevant questions in the history and also in the examination, important findings for each of the differential diagnoses. We all know that maybe common things occur commonly, but they just want to give a summary. Like if you're answering this question, these are the differential diagnoses that should be on your mind as you go along in writing the discussion. And then we call it a day. Thank you so much. It's been a brilliant presentation.
Okay, so a case of a 60-year-old patient with sudden loss of vision and a non-hypertensive. So the likely differential diagnosis should be targeted towards this background disease or background condition of this patient. That's the catch for mentioning hypertensive and 60-year-old. So the differential diagnosis could be as a result of a direct effect of this hypertensive retinopathy, or a direct effect of this hypertension, which could be as a result of hypertensive retinopathy. It could be hypertensive choroidopathy, however, not very common because of the age. Choroidopathy is commoner in younger age. It could be hypertensive optic neuropathy. It can occur in all ages. And it could be as a result of macular edema, maybe from indirect effect of the hypertension or hypertensive retinopathy, as in the case of central retinal vein occlusion, or branch retinal vein occlusion, or branch retinal artery occlusion. It could also be as a result of an ischemia to the macula, probably if there is associated central retinal artery occlusion or branch retinal artery occlusion. And also, the sudden loss of vision in this patient could be as a result of macroaneurysm, especially if there is hemorrhage, retinal hemorrhages, maybe retrohyaloid hemorrhage. Most commonly, macroaneurysms do rupture and form a retrohyaloid hemorrhage. So if this retrohyaloid hemorrhage is at the level of the macula, it could also be a likely cause of this sudden loss of vision in this patient. So these are some of the causes of sudden loss of vision in hypertensive patients. If this patient is also diabetic, he could have an exaggerated diabetic retinopathy. It could also be the likely cause of loss of vision in this patient. And usually, the loss of vision is usually painless, only in certain associations, maybe in giant cell arthritis.
Thank you very much, Dr. Abdulkarim. I think we have a long list already of differentials of sudden loss of vision in 60-year-old hypertension. And I'm sure we've all benefited from this presentation. I don't know if Dr. Nurat Adeleye has any comments or any information to pass across for Dr. Baturi.
Okay, thank you very much, Dr. Abubakar. It's been a wonderful presentation, really. I think for young residents, they need to go back and go over it. He went to town to explain the pathogenesis so that it's even easy for everybody to know the differential diagnosis and why those differential diagnoses come up. Maybe somebody mentioned AIO and the non-arteritic type. That is what he meant by saying optic hypertensive optic neuropathy, also including non-arteritic anterior ischemic optic neuropathy. And then he mentioned that if it's painful, then we can be talking about the giant cell arteritis. So thank you so much, Dr. Abdulkarim. I don't have any further comments. Let's meet again another fortnight and gain from each other. Thank you.
Thank you very much. Do have a nice day.
Thank you. Have a lovely weekend, everyone. Bye.
Bye. Thank you.